This lecture is about O&P terminology and components. It'll be an introduction to some of the basic terminology you need to know to understand the literature you're going to read during the course, and also get you a little bit of basic knowledge of some of the terms we use to identify components and different types of prosthesis and orthosis. We are going to cover planes of the body, anatomical terminology, the gait cycle, prosthetic terminology, and orthotic terminology. We're going to start with the planes of the body. It's important when working and talking about the body that we are able to describe different locations, different orientations, and everybody in the medical field uses the same language for this. So the terminologies that we're going to learn about today are some of the planes of the body. As you can see in the picture, the planes of the body can be divided into one that goes from the front to the back, from side to side, and then cuts through the center, sort of like a tabletop does. The first one we're going to talk about is the sagittal plane. The picture here illustrates the sagittal plane. It goes from the anterior to the posterior of the body. And you can kind of think of it as a plane of glass going through the body. If you have a hard time remembering it, you can kind of think of a squirrel. And if you see a squirrel here, you can only see his tail from the side. If he was facing forward, you couldn't see his tail. But from the side in the sagittal plane, you can see his tail. So kind of think of a squirrel's tail to remember that. The transverse plane is sort of like a tabletop. So if we put a table here, and let's say we have an electric train on top of it running around the table, that would be the transverse plane. And it's best viewed from the top, like you're flying in a helicopter over the top of the patient's head. So when we deal with the transverse plane, that's a horizontal plane that goes through the body. This picture down here is a depiction of the frontal or coronal plane. This one goes from side to side, and or it's from the medial to the lateral side of the body. And I think of it as sort of as a crown of the coronal plane. You always see the king of the in his throne, and you always see him from the frontal plane, viewed from the front. So when you view the frontal plane, you always view that from the front. We also need to talk about anatomical position. It's also good to be able to describe things on the body using some directional terminology. And some of the terminology that we're going to use all the time are some of these listed on the screen. The first one we're going to start with is the superior and inferior. Superior means above, inferior means below. Generally, this term is used for the trunk of the body, so this section right in here. We generally do not use these terms for the limbs, just for the trunk. So if we were talking about this patient's umbilicus or their belly button, we would say that the belly button is inferior to the sternal notch, which would be right up here. So, and the sternal notch would be superior to the belly button. So it's a up and down type of thing. One's superior, one's inferior. With all these terminologies, there's usually one or two words that we use for the same thing. So superior can also be referred to as cephalic. Inferior can also be referred to as caudal. So if something's superior or cephalic, that means the same thing. It just really depends on when the person who's giving the lecture was trained, what words they're going to use. So you kind of got to be aware that a lot of medical terminologies have one or two words that mean pretty much the same thing. Another one we need to learn is lateral and medial. Something is lateral if it is farther away from the midline. So if this is the midline of the body, the line going straight down the center of the body, this person's ear is lateral to his nose, and his nose is medial to his ear. Now, just because I said here that the nose is medial, it doesn't always have to be medial. So if we talk about the eye and the ear, the eye is medial to the ear, but the eye is lateral to the nose. So you have to make sure it's describing the area that it's referenced from, so it's a point of reference that it's working with. There's also the anterior and posterior. So anterior is the front, posterior is the back. It's also said as ventral and dorsal. You can think of the dorsal fin on a dolphin or a shark. You always see that coming through the water. Actually, not a dolphin, a shark. And you always see that coming through the water in all the horror movies. So that would be on the dorsal side. That's the dorsal fin. That's going to be the back of the shark, or the posterior. And ventral is the side with the most openings, which is your mouth, your nose. So you have more openings on your anterior side. There's also the terminology that we use for limbs. Instead of using the superior and the inferior, we also use proximal and distal. And proximal and distal refers to the limbs. You don't use this on the trunk of the body. So this person here, the knee is proximal to the ankle, and the ankle is distal to the knee. The toes are distal to the ankle, and the ankle is proximal to the toes. Those are some ways that we can describe position on the body. We also need to be able to describe some of the motions. In this picture here, the red line indicates flexion of the hip joint. So the motion's occurring up at the hip, so this would be flexion. The blue line indicates extension of the hip. So if this person was to bring their leg down, this would be extension. This one over here is showing flexion of the knee. That would be the red line. And the blue line here would be extension of the knee. And this fellow over here in the video is going through a series of extensions and flexions. So he's flexing the knee, he's extending the knee, flexing the knee, extending the knee. There's also another term that we use called hyperextension. There's a normal range of motion that we have, and the knee is usually about 180 degrees of extension. If for some reason the knee is pushed past that, that would be called hyperextension. And most joints can go into hyperextension to a certain limit, but very much past it, and there's usually a damage caused. So I like to think of flexion and extension. If you think of a fetus in the womb, generally when you're in the fetal position with your hips flexed and your knees flexed and elbows flexed, all the body parts are in their flexed position. And that's going to be the smallest ball that the body can get into. When you think of the extended position of the joints, think of a person standing straight up with their arms stretched out to the side as far as they can go. That's kind of the largest space that we can occupy, and all the joints at that point are in an extended position. At the hip, we can also have adduction and abduction. So if we adduct the hip, we're bringing it in towards the midline. So with this guy just standing here with both feet on the ground, he's in an adducted position. If he was to raise one leg and push it out to the side, that would be an abducted or abducted position. These words are very close in how they sound, so it's a good idea, instead of saying adducted and abducted, to say adducted or abducted to make it more clear when you're talking to somebody. So this lady down here, even though her knees are in flexion and her hips are in a slight amount of flexion, she's still adducting and abducting her hips. Another way to remember this is abduction. Abduct, if you were abducted, someone abducted you, they would steal you, take you away, and just think of it as going away from the midline. So just remember, abduction is taking away from the midline. We also have rotation, and to describe that we use internal and external rotation. The rotation is happening up here in the hip, and you can see his foot is pointing out. That would be an example of external rotation because his foot is being externally rotated. Internal rotation would be if his foot was pointing towards the other foot here. So if he rotated his foot in, that would be internal rotation. And this would be an example over here of internal rotation. We also use plantar flexion and dorsiflexion. Dorsum is the top of the foot. In this section right here, plantar is usually referred to as the bottom of the foot. So if we dorsiflex, we're going to do this white line here, and it's going to go up in the air. So we're going to lift our toes up in the air, and our ankle is going to dorsiflex. On this one down here, it's plantar flexion. So we're pushing down towards the ground, or the plantar surface. So we're going to push down, that's plantar flexion. When we plantar flex, It's similar to stepping on a gas pedal, same motion that you use in your car when you step on the gas pedal. So that's dorsiflexion and plantarflexion. At the heel, looking at the back, we can also do inversion and eversion. The inversion would be as if the heels are pointing in towards the midline. So this is inversion because the heels are pointing in towards the midline. Eversion would be heels pointing out away from the midline. Again, inversion and eversion. And those are kind of some of the terms that we use to talk about the body and explain what we're talking about as technicians and practitioners. This is just kind of a brief overview. You're going to want to read along in your books that you have to get a better understanding of it. But this just kind of gets you familiar with those items. The next thing we're going to talk about is the gait cycle. Locomotion, ambulation, and walking. They all pretty much mean the same thing. It's how we walk. So the gait cycle just describes that. If you look at this fellow here, and without any understanding of what gait is or any of the terminology that you use to go with gait, you can pretty much say the cartoon character is just walking. But if there was something wrong with his gait, you really couldn't describe what was wrong with it. You could say maybe he had a limp or something like that, but that's about all you could do. So it's nice to have some kind of terminology and an idea of the gait cycle, so when something's wrong, we can say there's a problem with the stance phase or swing phase, and we can have an understanding of what we're trying to deal with on the patient. You can break gait down into some basic components. The first ones that you can break down into is stance and swing phase. Stance is when you have your foot on the ground. So if we're just looking at this person here on his right side, you can see that his right foot is on the ground. So he is in stance phase because that limb is supporting his weight, so he's standing on it. If you go over here and you see the yellow leg over here, you can see that his leg's up in the air and it's swinging through the air. So we call that swing phase. Stance phase occupies more time than swing phase. So you're standing on one leg longer than you're swinging it. And when you're just standing on one leg, we call that single limb support. So if you're just standing on one leg in this time period right here, that's single limb support. If you're standing on both legs during the gait cycle, that's double limb support. So each leg has a period of single limb support, double limb support, and a swing phase. The stance phase can be broken down into a few basic ones. The first part of stance phase is called heel strike. Heel strike is when your heel first hits the ground. So that's considered to be heel strike. As you walk along, your leg assumes a more vertical posture, and that's called mid stance. So that is where you're taking most of the weight on your leg, and usually the other leg is in swing phase at that point. Then, as you go to toe off, this is where you've gone past mid stance and now your toe is about to leave the ground. The other limb is now supporting most of the weight, and it's the beginning of swing phase. So we go from toe off into mid swing or swing phase, and then we go right back to heel strike. And that's kind of the gait cycle: heel strike, mid stance, toe off, mid swing, and heel strike. This period of double support here is when you're at the most stable, because you have 2 feet on the ground. The definition of running is when you no longer have double support. So when you transition from walking to running is the point at which you no longer have double support, and you actually have periods of no support at all when both feet are in the air, and that's kind of how you define running. There are lots of different ways to define the gait cycle. There's a few different authors that define it with different terminology. For what we're going to do in this course here, this is about what you need to know, these basic gait cycles here, and I would suggest that you review this in your manuals and your books so that you can better understand it. Another thing about gait is that we have a center of gravity. So the center of gravity is a point right about in the same area as your umbilicus or belly button. So that center of gravity while we walk moves up and down about 4 inches. So as you walk along, you just don't walk in a straight line and your head doesn't stay at the exact same point. You kind of bob up and down a little bit, and that's your center of gravity oscillation. And this is kind of a picture of the oscillation of the center of gravity. It kind of goes up and down as you walk. It also swings side to side about 2 inches each way, so it makes a sort of a spiral as you walk down the road. And a lot of times, basically the flatter this graph is, or the less that our center of gravity oscillates, the more efficient we are at walking, because our weight's not moving up and down. It takes energy to do that. The more narrow that is, the more efficient we are. So when you have an amputation or a brace that we put on a patient, a lot of times they have a bigger oscillation, so it takes them more energy to walk than what it does if you had a normal oscillation of your center of gravity. So that's kind of the terminology and the gait that we're going to go through. Now we're going to start focusing on some of the different types of prosthesis and orthosis. And we're going to start off with amputation levels, types of prosthesis, anatomical landmarks. Some of the rules about naming the amputation level are generally they're named after the bone that is cut during surgery. So if you have a transtibial amputation, most likely they cut the tibia when they did the amputation. If it's a transfemoral, they cut the femur when they did the amputation. Disarticulations are usually named after the joint that is disarticulated. So disarticulation is when you don't cut any bone, you just cut through the joint and cut the tendons and the muscle that are holding the joint together, and you leave and you kind of separate it at the joint. And so if that was done at the knee, that would be a knee disarticulation. If it was done at the ankle, it would be an ankle disarticulation. And most amputations have 2 common names, and this goes back to the fact that people are trained at different times and terminology changes over time. We used to call amputations below the knee a below knee amputation. Now we call them transtibial amputation. So transtibial is the newer, more correct way of speaking about that amputation level. Below knee amputation still needs to be known, so if someone talks to you in those terms, that you'll understand what they're talking to, and they're also called BK amputations. So a lot of times there's more than one name you have to remember. Prefixes and terms. Some of the most basic ones to understand the amputation levels are trans, which means across, dis, which means apart, hemi, which means half, bilateral, and unilateral. You'll hear transtibial, transfemoral used a lot in prosthetics. Dis would be part of disarticulation or apart. Hemi just means half, so if half of something is missing, a lot of times they call that a hemi. Bilateral is when both sides are effective. So if I'm a bilateral amputee, I've lost both my feet most likely, or both my hands. If I'm a unilateral amputee, I've just lost one foot or one hand. There are lots of different amputation levels, and again, most of them can be divided up into disarticulations and standard amputations that cut the bone. Down here we have a Symes amputation, BK or transtibial, AK or transfemoral. We're going to go through all these in the next slides. This is just a picture to kind of give you a visual of where these amputation levels happen at. When you're talking about amputations, it's kind of interesting to know which amputation level is most common. And by far, the below knee amputation level is definitely the most common, and the above knee amputation is the next. And you can see that the rest of the amputation levels are very minor. So when you get out to work, you're probably going to see mostly below knee amputations, and then the rest of them are going to just kind of trickle in at different rates. A lot of people think that most amputations are caused by accidents or trauma, but in reality, most amputations are caused by disease. Diabetes, poor blood circulation, infections and things like that are what cause most of the amputations, and they're mostly in the elderly populations. Accidents are 23% and birth defects are 3%. So when you think about your typical amputee, you're probably going to picture a person around 60 to 65 years old, maybe a little older, who has diabetes, poor blood circulation in their feet. That's kind of the typical amputee. Of the different types of lower limb prosthesis, there's the partial foot, the signs, transtibial, knee disarticulation, transfemoral, hip disarticulation, hemipelvectomy, and hemicorporectomy. This slide here is showing you some of the different partial foot devices that we can make. This here is a typical toe filler, or I'm sorry, a partial foot. The patient's probably lost their toes due to diabetes or poor circulation. You can kind of see the skin is somewhat dry and cracking, and so this is probably a diabetic patient. What we can do for them after the amputation is we can make them a simple toe filler like this that's going to fill up the shoe. This will keep the shoe from collapsing, and it'll keep the end from turning up as they walk on it. It'll also give them some protection inside because we have a custom molded insert in it that's going to protect their foot and distribute some of the weight equally. There's also going to be a silicone boot, which is a silicone partial foot, and this would be more of a cosmetic restoration. Someone who wants to wear sandals or just likes the looks of a cosmetic restoration. Symes prosthesis. This is a typical Symes prosthesis. This was named for a Dr. Symes who invented the amputation level. It's a type of disarticulation where they replace part of the bone back up into the mortise of the tibia and the fibula, and then wrap the heel tissue back around it, so they still have a heel pad, as you can see down here. This was actually the patient's heel before the amputation. These amputation levels have the advantage of being able to bear weight on the distal end of the stump, which is this area right here. And that makes it so if the patient has to hobble out of a house in the middle of a fire at night or something, that they can do that without the aid of a prosthesis. So it's kind of a nice safety feature for the amputee in that respect. It also has a nice long lever arm on it, and a long lever arm means they're going to have good control over their prosthesis generally. However, the extra bulk down here makes it hard to put a prosthetic foot underneath it. It also makes it difficult for this to look cosmetic at all. So cosmesis is going to be an issue with this prosthesis, and there's also going to be some weakening by cutting this big door into the prosthesis. So strength, foot selection, and cosmesis are all going to be a problem with this prosthesis.